So that we, okay, so we can go ahead and get started. Um, I know Dr. Escuday has a great presentation prepared for us today on use of psychotropic medications in people with IDD. So we'll just move forward to the presentation, if that's okay, Dr. Escuday.
That is okay, as long as you give me a minute to put
Of
everything
course.
in the right screen spot and all of that kind of
Abs
good
you
stuff.
take all the time you need.
Give me about 30 seconds or so, and I think I'll
Of
have it lined
course.
up.
Of course.
Maybe. Okay. Let's see. I think we have it. Okay. Can you see the thing that says psychotropic medicines, tips
Mhm.
for prescribing for people with IDD? Okay,
Absolutely.
good. All right. So here we go. 1 second. All right. All right. I'm ready. I expect it to have a little bit more time while we're doing it,
I'm
but we don't
well,
need that.
normally you would.
I am ready. Here we go. All right. So you guys know who I am. Program disclosures, we've seen before, CME joint providership information there. So real quick, I want to just touch on dual diagnosis before we get into
Mhm.
medications. Dual diagnosis, can mean a couple of things. Many times in the mental health field, when we hear dual diagnosis, we think of a person with a mental health condition and a substance use disorder. But what we're talking about in this field when we hear the term dual diagnosis is pretty much a person with an intellectual and developmental disability and a mental health condition. It can include substance use issues as well, but that's really if you hear the term dual diagnosis in this talk and in this field, it usually means someone with IDD and a mental health condition. Now, we know that about 30 to 35% of people with IDD have a psychiatric disorder, but we also see in some studies that about two-thirds of people with IDD can be on psychotropic medication.
Mhm.
So what this often tells us is that there's a lot of people without a true psychiatric diagnosis that are being treated with psychotropic medications. And the inference here is that they're being treated for these adverse behaviors or that they don't have a really good psychiatric diagnosis because it can be very challenging to get a good psychiatric diagnosis, especially in people who don't use words to communicate. I've said this before, always consider behavior as a form
Mhm.
of communication and not really as a problem or a challenge, but what is being communicated. We know that behavior has lots of other functions. Sometimes people might use it for a sensory experience. They like whatever the behavior provides to them from a sensory standpoint. Maybe triggering some internal sensations or internal rewards. Sometimes people use behavior for escape or avoidance of demands when they don't want to do something. Sometimes they use it to gain attention from others. Sometimes there can be tangible items that they can gain from, access to something, a certain place or a certain person or a certain situation or attention or a reward that
Mhm.
might be provided. So there's other reasons people have behaviors too, but when we look in big categories why people have behaviors, many times it's a normal expression of emotions. We all use behaviors to express emotions sometimes. We always have to talk about and think about, is there an underlying medical condition that is causing some sort of change in a person's behavior? We also have to recognize, could it be a mental health condition that's causing a change in that person's behavior? And then we also have to think about abuse because we know that abuse is more common in this field, and certainly that can cause changes in behaviors as well. So let's jump into some info on psychotropic medications. So these are some wordy statements, but they're worth kind of going into a little bit as far as general considerations with psychotropic medicines in this field. When we see what we call problem behavior like aggression or self-injury, we need to recognize it's not always a psychiatric disorder, but it might be a symptom of some other health-related disorder or a circumstance, including things like insufficient supports, that the person is not being supported in a way where their needs are being met appropriately, and that can result in some sort of problematic behavior. Sometimes they occur, as I said earlier, because the environment does not meet their needs of the person. And sometimes, and of course, I can't say this enough, but underlying medical conditions. But what we also recognize is that despite often that there's absence of some evidence base for prescribing psychotropic medications, they're often used to manage problem behaviors in people with intellectual and developmental disabilities. But we should never think of them as first line or routine. There are instances where it is important to use a medication to stop someone from hurting themselves, from hurting other people, or whatever the case might be. We see sometimes that a person is um, put on medications to improve their behavior so that they can remain in, say, a community setting, a community environment. Otherwise, they might need a higher level of treatment. Not saying that's always the best thing to do, but sometimes that can be done. But we should not see that as the end point, or like, okay, we put them on a medicine, they're zonked out now so they can stay in this community setting because they're not causing any more trouble. We always need to be figuring out why, be looking at reasons why the person is having this behavior. Um, and always consider other interventions either at the same time or before, depending on the circumstances, jumping to medications. Sometimes psychological or behavioral therapy can help, environmental modification. Sometimes it's a communication issue. And if you help a person to be able to communicate better through story aids or talker type devices, that may alleviate a lot of these challenging behaviors. And then looking at sensory aversions or sensory seeking behaviors as well too. So always looking at this from more than a standpoint of, oh, let's put them on a med and stop that behavior. Establishing a diagnosis of a psychiatric disorder in adults with IDD is often very complex. It can be very challenging. How can a person tell you what they're feeling or what they're thinking or what's going through their head or what thought disorders they might be having if they can't tell you verbally what's going on? So we always have to look at it from an observational standpoint and get a lot of people's view on what might be happening and all of their supporters, and looking at context and when these behaviors occur and what might be going on. And it's challenging. In general, though, we know that the more I don't know if this is the right word or not. I want to say easily treatable, but mood disorders, anxiety, adjustment disorders are typically underdiagnosed, and people end up being overdiagnosed with some sort of psychotic disorder, and they get put on these big psychotropic medications when it could be something, the other way around, or the balance is off here in this situation. Antipsychotic medications, we know, have side effects, several, but one of the big ones to remember is metabolic syndrome. So, hypertension, obesity, glucose intolerance. So they can have long-term physical implications of people being put on medications for behavior that can subsequently cause lots of other problems. They can also have lots of other effects like akathisia, some cardiac conduction problems. They can interfere with swallowing, bowel dysfunction, increase the risk of constipation, cause sedation, reduce the quality of life because a person is sedated, can't think as clear, they can't interact with their community as well. So there are lots of good reasons to be very, very judicious and very careful when we're using these medications and any medications that have the potential for significant side effects, interactions, and long-term complications in particular. One of the things we often see is that people get put on this psychotropic medicine at some point in their life, and maybe they move to a different level of service, a different place. Nobody knows why they were on it, but hey, they've always been on Seroquel, so they're going to stay on Seroquel for the rest of their lives because nobody wants to take them off of it because they must need it for some reason. So we always have to be looking at, can we reduce medications over time? The goal is not really or shouldn't be just to treat the behavior, but really to identify the underlying cause of the behavior disturbance and treat that. Identifying the underlying cause often requires a multidisciplinary and interdisciplinary team approach with multiple people bringing their expertise in as to what might be happening. And where the cause is not easily found, despite investigating for underlying medical conditions, environmental contributors, behavioral concerns, emotional issues, or psychiatric disorders, then you might still consider a trial of medications that might improve that person's symptoms if it can improve their overall quality of life, balancing the risks and benefits. And I want to make a point here that when we say, despite a thorough investigation for medical conditions, we know that many healthcare providers don't know how to do a thorough investigation for medical conditions in people with intellectual and developmental disabilities. So we have to ensure that the provider has that ability, has that understanding, that knowledge, that recognition. Because what we see is that people in the field might say, "Oh yeah, we know he needs a medical evaluation," so they know that, so they take him to the doctor, but the doctor really doesn't know what to look for exactly. All of the complex connections between behavior and underlying medical conditions. And so they get an evaluation. Then the psych team says, "Oh, yep, they had their medical evaluation, but maybe not everything was addressed, so including dental concerns." So it's important to recognize that aspect of it as well. When we're treating behaviors with medications, let's say the decision is made to do that, you know, we need to know what we're treating, have a very clear target on what we're treating, what we're looking for, monitor it, and ensure that the medications are actually having the effect that we're going for. And if it's not, we need to look at other things. Changing medications should typically be done very slowly, and unless there is a, um, an emergent reason. For instance, valproic acid can cause thrombocytopenia, and if it's low enough, that can increase risk for bleeding, and that would be an emergent reason to quickly take someone off or reduce the dose at least of valproic acid, which is sometimes used for both seizures and mood stabilization. But then you also have to remember the anti-seizure aspect of the medication. And when a person's been on an anti-seizure medication for a long time, even if they don't have a seizure disorder, or maybe they have a well-controlled one, if you abruptly remove a medication for seizures, it can cause a seizure spike. So lots of complications and complicating things to consider with medications in this field. That's yeah, bullet point number 3. And when you're starting a medication trial or you're changing to a new medication, let's say you determine this one didn't work, do your best to withdraw the previous trial and do it slowly. And sometimes, if you need to, you can, be at a point where you're withdrawing one medication as you're ramping up another one. There are different ways to do that. The key is to go slow and look for changes that a person may not be able to tell you. Changes in level of alertness, activity, not eating, constipation increase, change in behaviors that are not what you expect. All of these different things, and you've got to have support staff monitoring them for these changes when medications are being or when they're being adjusted or changed. All right. Big side effect categories with psychotropic medicines, extrapyramidal side effects. These are usually movement type things that cause other problems. So it's a drug-induced movement disorder. You might see it as a tremor. You might see slurred speech. You might see akathisia or difficulty moving. You might see dystonia, jerky movements, not having good smooth movements. You can also see some anxiety and paranoia. Those could all be signs of extrapyramidal side effects. And the other one is TD or tardive dyskinesia. These tend to be more certainly they're involuntary. The other ones are too, and they're usually kind of these repetitive body movements. Often you'll see it in a person's mouth where they're doing some funny mouth movements or lip smacking, sticking their tongue out. Those things can interfere with a person's ability to eat. So remember that and drink.
Mhm.
eye blinking, pursing of the lips, and sometimes rapid or unusual movements of the limbs and or torso that can even interfere with the person's ability to walk. These things are typically more long-term and can persist after the medication is discontinued. EPS typically will go away when you stop the medicine, or sometimes you use other medicines to treat that. TD many times will not go away, and they can be lifelong conditions, even if the person's on the medication. Again, another very good reason to be very careful in using psychotropic medicines. There are some medications that have come on the market recently. One of them is Ingrezza, and I can't remember the name of the other one, that have come out to treat tardive dyskinesia, and they're showing some positive results. But it would be better not to get it than to have to treat it. All right, classes of medications and their side effects. I'm going to pause really quickly before we get into that and see if there are any questions or comments.
Hey, y'all. Sorry, I was a little late. But just one comment on the tardive dyskinesia that we see a lot from the oral health standpoint is ulcerations under the tongue from that rapid tongue movement, and they scrape it against those lower teeth. And it actually causes ulcerations underneath the tongue. So, hey, open your mouth and let me look inside, stick your tongue out. You never see it because it's actually on that underneath side of the tongue.
Thank you, Betsy. That's really fascinating. That's not something I'd heard before. So that's very interesting. All right, so let's just go over some classes of medications and their effects. This is by no means is a review of anybody remember PDR? Natalie, did you use the book way back?
So it was on its way out because what was a Palm Pilot or whatever that thing was like,
BlackBerry or all that.
BlackBerry. That was a thing when I was starting medical school. So
yeah, we were still using the big old book and when I was there. So we're just going to look at some big picture classes and then talk about some effects. So psychotropic medications, there are what we call typical and atypical antipsychotics. Typical are the older antipsychotics, mainly Haldol and Thorazine. Lots of side effects, lots of EPS, lots of tardive dyskinesia. The atypical ones are the newer ones, and that's what we see that most people using. But people still are on some of these old medications, and it might be a good idea to wean them off and move them to a newer one if they still need those medications at all to begin with. But the atypical ones still do have side effects, still do have the capability to have EPS and tardive dyskinesia. We also see sedation and confusion a lot with some of the older ones, and we can see it with the new ones too. But the idea with these newer ones, these atypical ones, they're supposed to have less tardive dyskinesia, less extrapyramidal side effects. Which we do see less, but they still can occur. So don't think, oh, they're on an atypical, they're not going to have any problems. But you also tend to see weight gain, diabetes, hyperlipidemia. Those are the metabolic syndrome components there. And again, it's with long-term use. And then you can also see some cardiac changes and changes in the QT prolongation, which can lead to some arrhythmias as well too. So definitely think about those things when you're prescribing or see people on those medications. Psychotropic medications in terms of mood stabilizers. So the more common ones you'll see are things like lithium. It's an old one, it's been around forever, has a very narrow therapeutic range and a high toxicity. Depakote or valproic acid, which is the one I was mentioning earlier, that medication sticks in my head so much because I saw so many people have thrombocytopenia, and that is a major thing to watch for if you have a lot of people that are on valproic acid is thrombocytopenia. It is dose dependent, so if you reduce the dose, many times the platelet count will recover and come up. But in some instances, you do need to actually stop the medication. There's a case that I have in the course that I developed where, and this is 100% real, and what happened, I had a person with a seizure disorder that presented to that was brought into the clinic because she had bruises all over her chest, and they were just on her chest, chest and abdomen somewhat, but mostly on her chest. And it's like, okay, wow, did somebody beat her up? What happened? What's going on? Of course, you've got to think about that first. But of course, she was on valproic acid. Check a platelet count, it was like 20,000, which is very low. And what had happened is she had had a seizure the night before, and she was in her wheelchair, and she wears a chest harness for positioning, and she was having her seizure against this chest harness, and the bucking caused all of the bruising in combination with the low platelet count. So that was a very memorable case for me. You also see, this is a seizure medicine also. Lamictal can be used for mood stabilization. Tegretol, another seizure medicine, and Topamax. You'll also see these dually used for seizures and for mood stabilization. And remember what I said earlier about recognizing the seizure or anti-seizure impact of these medicines. If you're using them for mood stabilization, be careful about abruptly withdrawing them because it can affect the person's seizure threshold. Anti-anxiety medications. These are things like benzodiazepines. I don't like to use benzos very much in this, especially in this population. Not so much for the abuse potential, which they do have, but they cause you to think fuzzy and they're sedating. And when you have a person whose baseline of cognitive function is already, a little compromised, why add medications that can do that? Other things you might see are like things like Lexapro, and other SSRIs, Paxil, and SNRIs, and you'll see Buspar. You also will see propranolol and clonidine used in this field for anxiety, and sometimes for behavior. To be honest, I'm still not fully clear what the appropriate criteria are for propranolol and clonidine. I've seen them used. I've seen psychiatrists, put them on it, but I'm not 100% sure how or why they're that helpful. I know there's information out there, but it's just always been kind of a weird thing to me because I'm a family doc, and I'm like, those are blood pressure medicines. So, and you do have to be aware of that, or those effects. So antidepressants, again, SSRIs, Zoloft, Lexapro, Celexa, Effexor, Paxil. You don't see too many of the old things anymore. All of the tricyclics and all of that, thank goodness, which those have lots of interactions as well. But these medications can cause sexual dysfunction. They can cause dizziness, nausea, particularly in the first couple of weeks. And if you know that, and you start someone on one of the SSRIs, for instance, and their balance is a little off, or they're not eating as well, you may decide to stick it out because we know that those two side effects in particular get better after the first couple of weeks. So it might be worth it, but at least you're aware, okay, they may be having a little dizziness or some change in behavior, but let's give it 3 or 4 weeks to see if that will go away. It can cause insomnia as well as somnolence, but insomnia as well, and sometimes aggression and a headache. So the other thing to think about is sexual dysfunction. We often assume, which is not true, that people with IDD aren't sexually active, but we need to recognize that sexual dysfunction with SSRIs is real and can cause frustration and problems, whether it's sex with other people or it's masturbation. If they can't get to the achieved goal, they may have other types of behavioral changes. So be aware of that side effect of those medications also. So in summary, people are often over or underdiagnosed with the mental illness. And remember those classes, the mood disorders are typically underdiagnosed and the psychotic disorders are typically overdiagnosed. Always rule out underlying medical conditions. We need to have really good clinical skills in trying to diagnose mental health conditions and looking for side effects by observation and looking for changes. Medications can have lots of unwanted side effects. The little mantra, start low and go slow. When you're starting a new medication, start it at a low dose. give it time to see if it's having an effect, both a positive effect and a negative effect, and then slowly increase it. And the same thing when you're coming down, it's best if you can to slowly reduce medications. And remember that we really need this biopsychosocial approach. We need to look at the person as a whole and not just as a behavior or as a challenge that we need to fix. So see them as people and recognize all of the different components that can affect behavior. So that is what I have for this. So I hope that was helpful.
Absolutely. Thank you so much, Dr. Escudé. That was
You're
amazing.
welcome.
And it brought up lots of memories going
Yeah.
going way back. One of the very rare, oh, it looks like Gina's coming in. Let her in real quick. Hey, Gina. So glad you were able to make it for part of the time. It's good to see you. Um, so yeah, brought up lots of memories for me. Actually, when I was much younger and in my early part of my career, um, when I was working at the developmental center, we had a person that, and often Tegretol that you mentioned is, used to treat behavioral mood disorder and so forth. But he got Stevens-Johnson syndrome.
Yep. Yep. It's another one to remember.
And it's very rare, but when it happens, it is something else. And so just, obviously, we had to be able to pick up on that very quickly, get him off the Tegretol, and we ended up, sending him for, to the emergency room just to, make sure
Yep.
he was in a place well supported to treat those the side effect symptoms, get him off the Tegretol and get him back and safe. But it's just one of those very rare things that most people wouldn't see.
Yep.
But Tegretol is one of those meds that
Topamax is as well.
yeah,
So, yep.
yeah. So just, there's so many things that, we want to be looking out for and thinking about. And the other one that I thought about, was heat related injuries.
Yep.
It can be a very much higher risk with a lot of these medications, especially lithium.
Yep.
We had a young man who was, is one of those really high heat index periods of time, which we're going through right now. He was on lithium. He was a quadriplegic as well. And within about 20 minutes of just sitting out on a patio, had a heat stroke.
Yeah, some of the psychotropics and lithium, they can impair the body's ability to cool themselves, making a person much more sensitive to heat. So every year at the large state hospital, mental hospital where I used to work, there was a July 4th celebration, and in Mississippi, and we all knew if we were on clinic duty that day, be ready, get the fluids ready and the cooling stuff
Yes.
because people were going to come in with problems. Yeah.
And it's, it's interesting because that whole incident completely changed many of our policies as far as, people, shouldn't be outside when it's hot, these are the temperatures, which it's okay. We're always got pitchers of water and fluids outside sitting ready. But yeah, those heat injuries can be severe. So we try to really focus on doing some health promotion for our communities about the potential for that.
So, speaking of that, before we move on, I want to call your attention to something here related to both of those things. I'm going to pop a link in the chat for two things. So this is a page where we have upcoming webinars, and we do free webinars they're 30-minute webinars every couple of months. The one next Thursday is so I always have a guest who's like a national expert in the field. The one next Thursday is on medication complications in people with intellectual and developmental disabilities by Nanette Roble, who's a well-known pharmacist in this field. So you can take a look at that, and you may want to join if that's something that is of interest to you. And then related to heat related problems, this page has a lot of resources, including some downloadables. And we developed a couple of years ago one specifically, we call it the Great Outdoors Warm Weather Edition. And then we have another one for the Cold Weather Edition. And it's specifically geared to help supporters of people with IDD recognize some of the challenges and know what to do in warm weather conditions as well as in cold weather conditions. And there's a whole bunch of other free downloads on there too. So those two things may be of interest as well.
Those are amazing, and that will help me as well because we try to do health promotions for care management to really, every month to try to, focus in on having conversations with people we support and their families. And so this will give me amazing information.
Feel free to download any of those and share them, in the talks that you do, and you can use them as in services and all that kind of stuff. So.
And I appreciate also you sharing about Nanette because I've attended many of the, webinars that Nanette does. She's really wonderful.
Yeah, super knowledgeable about this field. And
absolutely. She just did one a couple of weeks ago on asthma and COPD and people with IDD. So, I mean, she just has a lot of
yeah, the 30-minute webinars around lunchtime. So we try to make them easy and accessible. And we have 750 something people already signed up for that one. So it's huge.
Yeah. Yeah. Amazing resources. Yeah. So do we have questions for Dr. Eskide just about the information about psychotropic meds that you guys can think of? Do you want to ask?
Now, Craig, I will say in peds, clonidine is used for ADHD some.
Thanks.
And so,
I remember.
yeah.
Yes.
One of the first patients I had as an intern at UNC peds residency was a kid with IDD. I don't remember how old they were. Let's just say 9. And they were like obtunded. They just altered mental status, low blood pressure, whatever. I think they got a spinal tap in the ER and blood cultures and all kinds of labs or whatever. And then I was talking with the family and the kid was on clonidine and had a clonidine patch. And they put the patch in the back center of the body so the kid couldn't get it because the kid liked to eat all kinds of stuff. So the child had actually managed to get it and eat it. And so like a day and a half later, he woke up and he was fine. But like, yeah, it's hard to know what in the world is going on sometimes.
Yeah.
So.
Yeah, that's a great story. I'm glad you reminded me of that use.
Yeah. With patches, I mean, we have to be so careful with, where they're placed. And even when you place them, where you think it won't be an issue.
Natalie, did you see much propranolol use for anything?
I see psych use it a fair amount in people with anxiety who maybe don't want to do anxiety meds because they're anxious.
Just more for the blocking component of it, the like the sweating and the nervousness and the jitteriness aspect, I guess.
I see it used a lot in kids who have migraines and anxiety.
Yes, certainly that.
And that's kind of it. I can't think of any IDD kids I had that had propranolol. Certainly a lot of them wind up at some point on some of the antipsychotics. And it's, as a primary care doc, and I know that Gina, you've experienced this, and Craig, you too, like it's a matter of time and resources. And when you're seeing 20 patients a day, you do the best you can. And then we have to like rely on case managers and care managers, but like, when do we have time to talk to them? And it's just an unfortunate system that kind of fails most people, especially people with IDD.
Yeah.
My son takes I can't even ever say it.
Propranolol.
Yes, thank you. Yeah. And he has cyclic vomit syndrome. So he has it for the headaches. I don't know if it's helping, but I feel like one of the side effects he gets from it, he gets hot spots. Have you seen that before?
Not from propranolol, but
I
haven't
mean,
seen a ton
I
of
would try
people.
to, he takes so many different medications. So I try to look up side effects from his medications. That was one of his newest medications. And he gets these red, they're just, he would have it on his arm and it's red. And I'm like, oh, that's interesting. Doesn't bother him, but I touch it and it's hot.
Hmm.
It's very interesting.
Hmm.
I might look.
The heat comes from the vasodilation, which is what makes it red as well. So it's something that's causing a localized vasodilation, I would think, is what it sounds like.
It's strange. It'll be like his ear one day, then it would be on a spot on his arm, then it would be on his cheek. It's not every
Yeah.
day.
Yeah.
It's just once in a while.
Some sort of
Strange.
unusual drug reaction, maybe like an
Mhm.
allergy of some sort, maybe as well.
Mhm.
I don't know,
I mean, it's
Natalie. What
not
do you thought?
Yeah,
itchy.
I would be surprised if it's propranolol. I remember in med school neurology using it for like people who had flushing. And they would use propranolol to kind of dampen that response.
Hmm.
I wonder if it could just be some localized histamine stuff, not causing a full-on like hive, but just the wheel part of the hive, the red and flushing.
Mhm.
But it's hard. I don't know. That's odd. Because you would think if it was a medication effect, it would happen more consistently.
Mhm.
And you said there are some days that doesn't
It's-
happen.
Yeah, there's some days it doesn't, but
Hmm.
it's frequent.
Hmm.
It's not daily, but it's
Yeah.
Yeah.
And the thing I would think about is, so did it start, when did it start, and did it coincide with any particular medication or change in environment or some other exposure or a change in your detergent or a
yeah. I
change
was
in
trying to figure
all of
out the
these.
medicine he last took. Yeah, that's
Yeah.
why I was pinpointing the latest, the newest medication he received. But I just brought up that he was, because when you said it was a blood pressure medication, I was
Mhm.
like, that's interesting because he takes it for headaches.
Yeah, it is used for migraine prevention. Yeah, so that as well.
Yeah. But I don't
Yeah.
know if it really works because he still has breakthroughs. So those are it's a really hard one to
Mm.
control for those kids have that cyclic vomiting.
Yeah. Well, this is a really interesting conversation for me. So I'll share some about me personally. But I have chronic idiopathic hives that I've not been able to figure out, and it's been going on for several years. And I get those localized hot areas too, in addition. And I've been to everybody trying to figure it out. And I went to an allergist and immunologist, and they were like, this is a dermatologic issue. This is not, they were saying it's not an allergy. It's not, and so I still haven't solved it. It's, it's very difficult to live with because not only does it get really hot and swollen, but it also itches at the same time. But anyway, just hearing that, about the potential allergy versus whatever was interesting.
Christy, one thing is, have you ever had an IgE receptor antibody test done? If not, that would be reasonable.
Okay.
That is something that is a relatively new test. I didn't learn about it in residency. I only learned about it because my child has autoimmune chronic hives.
Yeah.
And so she has an antibody to the receptor on the mast cells which hold histamine. And so anytime her body is stressed, particularly at the tail end of a virus, she
Yeah.
will break out in hives.
Hmm.
And like allergy panels negative, allergy testing negative. She's got non-allergic asthma as well. But long story short, she just has this autoimmune hive disorder. And so it has gotten to be so severe. I think this is June, let's see here, June 5th. She had like
Yeah.
full body again. And
Yeah.
anyhow, she's about to start on Xolair, which is omalizumab. It's one of those new fangled medications that targets the immune system in a very specific way.
Yeah.
And so she's going to end up being on that for 3 years, and then we'll back off and see how it goes.
Hmm.
But it's been a journey. But IgE receptor antibody. If you
Okay.
haven't had that done, that might be something to consider.
Absolutely, write that down. It's just amazing. It sounds very much like me, and I don't want to make, I mean, obviously we need to make sure we're speaking about everybody else, but it's just think, and it's something I guess maybe Lydia would want to consider as well, based on further review of what's going on with her child. But yes, I've had COVID 2 times and I broke out like crazy.
Ugh.
Yeah, it's very similar for sure. Yeah.
Mhm.
Thank you for that. I
You
wrote it
guys are
down.
making me itch.
And with this heat, it gets really.
Yeah.
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 So, and if we've got time, I want to throw out just a question, for, I will call us the providers that do, the one-time dose of something like an Ativan or a Valium for procedure related.
Yes.
What are I mean, we usually talk with the behavioral analyst and the psychiatrist and all of these, and the nurse that are all involved in the care. But what are things that you would recommend that we either avoid or be careful of? And are we approaching it the right way, I guess is what I'm asking.
Yeah, again, it's weighing the risks and the benefits. And sometimes, a person really needs that gynecological exam, or they really need that oral exam or eye exam or whatever it is. Um, if there's time, desensitization would be a better option, and sometimes you might need both. But if you really need something and it's important to the health or well-being of that person, I personally don't have a problem and used sedation, such as Ativan, to help facilitate different types of exams on a number of occasions. On occasion, the taking that a couple of steps further, and you see that a lot in dental care and in eye care as well, are exams under anesthesia, and whether or not that's indicated or not. And again, sometimes it might be necessary, but I also know that there are a lot of things, especially in the dental world, and Betsy, I'm sure you know about that you don't have to put somebody under and you can do a whole lot of dental care, more than you think you could, if you have the training, the understanding, and the equipment.
Right.
So I don't like to jump to those things, but I've used it plenty of times in people who just, they needed to be sedated for an exam because they needed the exam.
Yeah. And you're right.
Yeah.
OR is the last resort, not the first solution.
Yeah.
Well, my son is going in for a dental exam next week, and he's getting to that point where he does pretty well. And now he's getting a little stronger. And now I think he needs a little more calming, especially for x-rays. He bites, and I'm usually the one holding. And so I got a letter from the dentist to submit to my doctor or the neurologist to let me know, is it okay? If the parent, me, can give him something to take prior, because with all this medications, I can't do sedation in office because of his seizure disorder. So it's tough to get into a hospital to do any dental sedation. So in office, forget it. I think he would do great if he was just a little calmer, like, shut a tequila. But I could get him like hey, whatever.
Yeah.
That would help me at the dentist. I'm sorry. I don't like going either, because I get so much stuff done. But if I could get on like a little Valium, but if
Right.
I'm going to read my letter I got from the doctor this week and see what she says I could give him. But if you're able to give to the parents, say, hey, find out what he's able to take. I've had some parents who I work with, and they say, hey, I get my kid a Valium and he does great, because he's calm and it lasts for the whole hour. So you don't have to.
And just be careful. In North Carolina, there are a very limited number of drugs that that can be used under a dentist supervision. In that, even if the physician orders it,
Okay.
being treated by the dentist, so they still fall under the responsibility. So if you have questions, I'm happy to help you with that.
Okay.
But there are very
That's
few,
what I
and,
needed.
and as they are, quote unquote, have a disability or are elderly or have respiratory distress, or there's this whole long list,
Yeah.
the dosage is dramatically decreased that is approved for usage in office, which
I'm
makes
sure.
it difficult for us.
Sure.
Because, you know, we all know that a patient that we would normally give, 2 milligrams of Ativan to, or really want maybe 0.25 halcyon for, and we can't even use halcyon anymore, and we can use 2.5 milligrams of Valium.
Okay. And I know that
So-
and I know that the dentist did put in like, the list of things they were
Yeah.
allowed to give, and
Right.
then what the I sent it to the neurologist
Yeah.
and what they would, if it was okay. So
And
that's what we
there are
were.
different degrees of sedation privilege in North Carolina, and related to permits. So depending on, that's always a question to ask is, if you're taking them in for a procedure, do you have a sedation permit? And that will allow different ranges of in office use drugs versus what you can take at home versus all the way through IV sedation. So
Okay. Gotcha.
Greg, do y'all ever use magnesium at all to help, like for calming?
I did not.
Mm-hmm.
What's your experience with it?
I haven't really, but as I'm getting into this functional integrative stuff, like magnesium can be really calming. And so it is part of serotonin synthesis, and then melatonin is made from serotonin. And then the magnesium also it causes like muscle relaxation and nervous system relaxation. So like for kids who aren't sleeping well, instead of doing melatonin, you could do magnesium, and that could be done with like an Epsom salt bath where they actually absorb some of that through their skin, or it can be done with oral ones. And you wouldn't want to do like mag citrate because that one's not absorbed into that one, just stays in the intestines and like helps with constipation and causes diarrhea. You would need a different form of it. But I was just, as we were talking and I was listening, I was just wondering whether it would be useful for any pre-procedural stuff if it kind of
And
was like calming enough. I don't know.
What would be the dosage that is recommended?
I would have to look it up. I will work on that. I'll tell y'all what I came up with next week.
Yeah, I'd love to hear more about that. That's interesting.
Because I think in general it's pretty well tolerated, especially if you don't do the ones that cause diarrhea. And so if that can help, at least maybe they still need their Ativan or whatever, but maybe instead of 2 milligrams, they just need a 0.5 milligram. That'd be cool.
Yeah.
Yeah, it's a possibility. I don't know enough about it other than we used to order it for women that were in preterm labor way back in residency. So it does have smooth muscle relaxation properties.
Can I ask a client-specific question for somebody I support? So I support a young man, he's 20, he does have IDD and autism. He's on a whole bunch of medications. I can't even list them off, but lorazepam, Seroquel, Risperdal. Like every time he goes to a human rights committee, the pharmacist is writing me a novel and I am sharing that. And he's under, I think, more attentive care now, and they're trying to whittle that down. But my question is, he has no history of seizures for his whole life. And then in December of last year, 2024, he's in a group home. The group home doesn't administer the lorazepam for 10 days. Doesn't tell anybody. So cold turkey off lorazepam and then immediately back on. They just didn't pick it up from the pharmacy, and then immediately back on his normal dose. So the day after they restart the lorazepam, he has his first ever seizure. A few days later, he has another seizure. He's on Depakote now. His psychiatrist clearly thinks it's related to that med admin error, but is there any likelihood that his seizure threshold is like permanently lowered? Is this an increased likelihood of seizures down the line? Anybody have thoughts? And also he's moving out of that group home. But anybody had thoughts on that?
I don't know about permanent lowering of a seizure threshold. I think that it definitely takes time to adjust with medications. That's why, you abruptly withdraw that Ativan. I'm sure that's what caused the seizures. There's no doubt in my mind. Did you say they started him on valproic acid since then for seizures now?
Depakote. I don't know if that's the
Their
same
Depakote
thing.
is valproic.
Yeah. Okay.
Yeah. I guess since maybe he had two, but see, I would look at that in this situation as maybe considering weaning that Depakote down and after he hasn't had seizures for a while because of, again, the added medication and added complications.
Right.
But I I don't know about a permanent lowering of a seizure threshold. It's just not something I'm familiar with or have heard of.
Okay.
I'm not aware of that.
It's good to know. Thank you. Obviously, his family has been very stressed about
Yeah,
that.
oh, I'm sure. Yeah, seizures are very traumatic for everyone involved.
Yeah.
If you haven't seen any or many of them and you see somebody have a seizure, it is a scary, scary event.
Yeah. Thank you.
And it
guys.
doesn't matter how long you work with people with seizures. They can
Yeah.
be really scary.
Yeah. And poor guy, 2 black eyes and bruises because he fell from
Oh,
Yeah.
high place. So anyway, that's good to know though. Thank you.
yeah. You guys, this is fabulous. Thank you. It's great information shared.
Yeah, it's great conversation.
Yeah, it is. I think probably we should move on to our case presentation. For those of you who were joining later, Israel had a family emergency. He had prepared a case presentation for us today. And so he had asked if Dr. Escudé could present that. So we'll let Dr. Escudé present the case presentation. And
Yeah. I know nothing about the patient, so I'm basically just going to read what we have on the form here, and I think probably we can go ahead and share. Let me share that while we do it.
yeah, we'll be able to skip the clarifying questions because
Yeah.
While you're working on pulling that up, it came to mind about all these patients with really complex medication regimens. If possible, it's really great to have a local pharmacy instead of a chain pharmacy because those pharmacists actually have a little bit more time that they can spend with patients and try to kind of do what they do well, which is think about how all these drugs interact with one another.
Yep. Good point. Trying to make this a little bigger. Hang on. Okay. So let's see. Patient is 22-year-old, a 22-year-old male. He has spastic quadriplegia, cerebral palsy, acid reflux, seizure disorder. He does not use words to communicate. He has a J-tube in place. Medications include baclofen, Prevacid, Keppra. So baclofen is for spasticity, Prevacid is an acid reducer, Keppra is an anti-seizure medication, and some other meds for his mother. That's always fun to deal with. And Ensure as well. And let's see, he's present in the office. He was born in Guatemala, has no health insurance. He's accompanied by his mother, 2 small siblings. She only speaks Spanish. Okay, this is challenging here. She states his J-tube is clogged and that Sprite and Coke are no longer working to unclog it. She is feeling very defeated and lonely, and she has to be home 24/7. And when he went to school, she got a break, she says. So you ask more about the J-tube, and the mother says, I don't know. I just want to give up. It's just clogs, and I can't give him his medicine. Physical exam, you noted multiple stage 2 pressure wounds, bed sores, partial thickness skin loss with exposed dermis. A local nonprofit pays for home health 8 hours a week. Unfortunately, there is a high turnover since the house does not have AC. Staff also complained about unsanitary conditions like roaches throughout the entire trailer. The trailer is small, and the only bathroom in the house is a very small tub, which is why he mainly gets sponge baths in bed. They also live in an area of town that is not very safe. They rely on the clinic van for transportation. So the presenting concerns: lack of insurance, what's available in North Carolina for undocumented patients, home health, how can they get more coverage, the role of care management for the uninsured, and caregiver burnout. Are there resources in Spanish or support groups for Spanish? So that's challenging. I have a little bit more information from his email, if you'll give me a second to figure out where that is. So he said, he said this is more of a case on social determinants of health and caregiver burnout. And in the end, there was little they could do for the family. We ended up partnering with charities and got his bathroom remodeled and got them a window AC unit and a new bed. And they applied pool noodles to the railings. And they also got him connected with Special Olympics and a big buddy from the local university. So those are good things that they did. I think, I guess we can just kind of discuss some of the challenges here. I think there are multiple, as we see, and caregiver burnout is a major problem, and you can imagine why in this particular situation.
I did reach out to one of our senior care managers, who's Hispanic speaking, does a lot of, work with Hispanic speaking families just to kind of say, hey, what are your thoughts on this? So I'm happy to share the information that he provided for me, but we'll go ahead and just see some thoughts that others here have. On how to
What-
support and Lydia, certainly from a care management perspective, and your thoughts, and with uninsured, undocumented, and that sort of thing.
What in North Carolina with like Medicaid or Medicare? I understand that's not this patient because he's not documented, but for respite care, is there a certain amount that's allowed per year, or how is that?
And I know Lydia can address
Yeah.
that certainly better than me, because there's the 1915 I, but
Yeah,
I'll
the
let you speak to that.
1915 I. With 1915 I, if they're able to get Medicaid, 1915 I waiver provides 300 hours a year for respite. And they can get 28 hours a week of community living support. So they can get someone in, to care for him, help him with his goals or his activities of daily living. But without the Medicaid piece,
Mhm.
gotta get that Medicaid. And of course, with everything going on, that's gonna be tough.
Yeah.
I mean, they're gonna have to do, community resources through churches. If they
Mhm.
belong to a church, sometimes there's some things to, I'm lost,
That's a tough one.
I know how hard it is,
Yeah.
especially moving to a new state. I mean, when I came to North Carolina, I struggled because they call everything differently,
Mhm. Mhm.
and every state does it differently. Coming from Virginia, with a child with a disability, you don't have to base Medicaid on the parent's income. You come down here and you do, and it's like,
Mhm.
what's his disability have to do with me when he needs a wheelchair? You're just, and then you're like, okay, well, what program do you need? I don't know. and you're like struggling looking, so families struggle when they move from place to place. I can't even imagine what it's like coming, when you're in another country and don't speak English. Um, yeah, they're gonna have a hard, like, they have to have a lot of connections with, they don't have other family members and connections to the community.
Yeah, I would say based on the interventions that Israel mentioned in his note, that I think they actually found some pretty good resources and really, yeah, it really did good. So they mentioned they got him connected with charities, got the bathroom remodel, an AC, a new bed. So those are, I'm sure, very helpful to him and his mother. Got him in special or connected with Special Olympics for the Big Buddy program from a local university. Yeah, I think it would seem like charities in general are going to be probably their main resource without being able to get on Medicaid. Um, I don't know what other comments to make. I will say that the J tube being clogged, this isn't the SDOH thing, but um, yeah, do you have any of you worked with J tubes and G tubes much? Not
I
so much.
no.
Um, that was an eye-opening thing for me. One of the other things we don't learn in medical school, to be honest, I didn't. I saw them. I saw people with them, but they were usually in the ICU for temporary reasons. They'd been there for a long time and they couldn't eat. I didn't see a lot of long-term patients with G tubes or J tubes, and if there were, it was the nurses who pretty much handled those things. So I had to learn a lot about G and J tubes because we had a ton of people that were using them for nutritional support and medications. And a J tube getting clogged in the middle of the night on a person who is either on continuous feedings or has significant medications, meaning things like seizure meds. If they don't get their meds, they're gonna, have problems. That can be a near emergency in some instances, or the tube coming out and it not getting addressed soon enough, and because after just several hours, that hole will close up and can be very difficult to just put another tube in. So they require urgent care most of the time. Even if a tube is clogged, it's still, of course, best to leave it in so you can potentially either unclog it or replace it. Clogging is significant, and that can depend on the type of formula that's being used, the rate at which it's being put in. If it's a person's on a continuous feeding, which we try not to do that unless it's just absolutely necessary from volume concerns. But the bottom line is there's lots of complications and problems related to feeding tubes, and not to mention the skin area around the tube itself and problems that can occur from leakage of fluids and acidic fluids, and you can occasionally replace a tube sometimes and it doesn't go into the place it's supposed to go, and you end up putting feedings into the abdominal cavity, which, as you know, is not a good thing to do and can cause emergent surgery for abscesses. Lots of complications with a feeding tube alone. Just to throw that out there, which hearing a mother with very limited resources, an inability to speak English, and also having to deal with the challenges with a feeding tube on top of that is pretty. But she's got a lot of challenges, no, on her plate for sure.
Do carbonated drinks break up a lot of the
They
clogs?
can. That's
Yeah.
why they use
Uh-huh.
Coke or Sprite. Sometimes the bubbly effect will help dislodge some of that. So they'll tell them to flush it with something like that, with Coke. Um, we 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 had a nurse. I love this guy. He was just he was I say cavalier, but I don't mean that in a Wild West kind of a way. He would do what he could do to the maximum of his ability to take care of things. And one of the things he would use is the wire that's in an endotracheal tube. That when you pull out the tube, he would take that a lot of times and feed it down into the J tube to try to push whatever it was out, and it worked many times and kept people from having to have a tube replaced. And of course, we replaced tubes all of the time where we were. But that was something as a physician I had never done. I had to learn to do it when I started at the program, and we did it a lot. I don't know, any other comments here, or thoughts? Um,
I know he didn't have autism listed as one of his diagnoses. I don't think that matters for the suggestion. There's probably enough overlap, but we have a pretty active Hispanic support group network across the state. And they do all kinds of grassroots. I mean, those people get things done. We've got a really active leader there. So it might be worth just connecting this family with them, if nothing else, to build a sense of community and to feel like she has some localized support and people
yeah,
who
that's a great
understand
point.
parts of her journey. So
And Craig, if you want, you can stop sharing. I'll share mine
sure.
and just show like what Francisco
Yep.
then just as a just some information that might be helpful. And I'll include this with our information from this particular session. But he kind of separated it out on some like lack of insurance and FQHCs, charity programs. And of course, MedAssist is amazing. If you're not familiar with that already, but for anyone who's uninsured, they are an amazing service. They do wonderful things. Some project access programs. He went into home health about, potential, getting a bit more coverage there and some thoughts. And then like the role of care management for uninsured, looking at different programs and transportation access that may be helpful. And then some different Spanish speaking support groups, like El Futuro that, is, does a lot of good work across the state, and the NC Latino Health Coalition and NAMI, and then had some specific educational materials and respite resources like Lifespan. Just again, some additional potential resources. This is a really difficult one. I think mainly trying to get connected with the LME MCO so that they could get some assigned support to help them work through, and having these options available to them.
Those are some great resources there.
Yeah, Francisco is very attuned to those, Hispanic resources that we have available across our state, and he's my go-to when it comes to. We've actually been working with a young 7-year-old male with fairly recent but severe pica that had a small bowel obstruction, and that happened during school. So we've been working very closely with the school team and mom to try to educate them about pica and what those supports are needed. And so we had a very successful updating IEP meeting, and so just we'll be talking in one of our 2 sessions from now about care management 1959 services. But there are a lot of things that we can do to advocate and support for families.
We heard about that at our meeting today. He was giving you kudos. Yes.
We got everything we asked for,
That
which was
is
amazing. Yeah.
That is good. I was absolutely shocked on that one.
Yeah.
I didn't realize I've done the Lifespan application for a family before. I didn't realize they didn't need to have Medicaid to receive that.
Yeah.
And it's a easy application to do online, and it gets approved fairly quickly.
Yeah, yeah.
And they get, I think they get like $500 worth, I think. So,
Yeah.
then they can pay someone to help for a little while.
Yeah, it'd be so nice if there was just a website for the state, right? That we could go to and if I'm
Yeah.
what?
Like some states have stuff like that. And then,
hidden gems.
yeah, and then I didn't see anything for housing I thought of, like, they have the habitat,
Mm-hmm.
I thought, there's that something to help. So I was thinking how they don't have AC and they're probably, I can imagine if they're having a tough time having someone come into their home because nobody wants to be inside the home and it's hot and it has roaches and
Yeah. Yeah.
Or sometimes First and Families will fund things
Yeah.
like that.
I was
That
wondering about
too.
that. That's a great
Mhm.
one, Whitney. Yeah, First and
Mhm.
Families often is a great support.
And they would need, assistance with filling that out.
Mm-hmm.
Can I ask what's probably an ignorant question that I should know the answer to, but will the LME MCOs fund anything for someone who is undocumented and therefore cannot access Medicaid? Like, is there anything through that pipeline, even if it's access to a care manager? I work with a lot of families who the child has Medicaid because they have the birthright citizenship for now, but the families don't have, parents don't have access to that, but maybe have some of their own unmet needs. Is there anything that an LME-MCO would do in a formalized way for those kinds of families?
If the child has Medicaid and they have an LME MCO,
Yeah.
you could get help for the family because it's helping the child. Because if the
Right.
child, say, is living in a bad situation, they're gonna.
Sure.
Yeah.
But if
I'm
nobody has
assuming-
access to citizenship or Medicaid, there would be no pathway.
If they have nothing, I don't think they would.
I think so. And this guy's 22. So, and they moved from Guatemala. So I suspect he's undocumented as well. With the situations that we've been able to really help and intervene and support is when the child has that birthright and get
Okay.
able to, and then even if parents are undocumented, able to get those services and supports for the family.
Okay, good to know. Thank you, guys.
Yeah, yeah, that's a great question. It's a hard one. It's a hard time to be even talking about it, but yeah, as we wait to even see what's going to happen with Medicaid.
Christine, aside about the patient you were talking about with pica,
Mhm.
so what got me down this whole integrative medicine path to begin with was in February, I did a PEDS question of the week, and I learned that you could have iron deficiency without microcytic anemia. I didn't know that. And then as I was reading more and more, I figured out you can have iron deficiency without anemia, period. And that iron deficiency anemia is actually the most severe form of iron deficiency. And so there are lots of people who have symptomatic iron deficiency, but have normal hemoglobin. And the
Yes.
PEDS neurology group and PEDS hematology group at UNC both have goal ferritins of over 50. More recently, they've been pushing them to 75, and lower limit of normal is like 15, or depends on your lab. But so some of these kids can have normal ferritin and still be low and still have symptoms of iron deficiency. It's incredibly common, and so anyone with pica absolutely needs it checked out. But ferritin is a much better measure of iron deficiency than using a hemoglobin. In like regular clinic with our teens, all our tired female teens who we did a finger stick hemoglobin on, we probably missed a lot of iron deficiency. And it's it has such vague symptoms that kind of overlap so many other things. But anyhow, I would just suggest a ferritin on that kid.
I am so glad that we had this conversation and you mentioned that.
Yeah,
Because
thanks, Natalie.
yes, I
appreciate
mean,
it as
step
well.
one obviously was I was trying to work with the PCP to talk, say, hey, this is going on, and how can we look at potential nutritional deficiencies? Is there, we need to rule out that underlying, in regard to the pica. And I know they did some labs and they referred him to GI. But I need to go into our system and try to see kind of what the follow-up, what were the lab results, so that we can then push forward and trying to figure out the underlying issue. And then of course there was the whole school piece that, we've got to get the supports that are needed there. And so, the school was great. But also, I mean, we're talking about a 7-year-old who was in the hospital for days with a surgical removal that happened at school. So yeah, very, very difficult situation. And he's regressed quite a bit since that, like back in diapers, not wanting to go to the bathroom because of all the manipulation. And so, yeah. Thank
Another
you.
thing, if he's not iron deficient, sometimes OCD can show up as kind of pica behaviors, like habitual hair pulling, eating, stuff like that. So
Right.
that would be another thought.
Okay. Great to consider, because we're just trying to do everything we can. It seems like the pica has even gotten worse since the incident.
Yeah.
Trying to figure everything out. That's really helpful. You guys think of anything else? Let me know.
So I'm slowly trying to write really short blog posts, like 1 to 3 minute reads on some of these things, so that, like, I just dropped the one about ferritin in there just because, like, I can't believe that I, as a pediatrician, didn't know that iron deficiency could happen without anemia. Like, I don't understand how I've managed to practice as long as I have without knowing that, but I'm not alone. Like, the papers really started getting published in earnest in 2017, and they're from all around the world in all sorts of disciplines. And it's a huge burden worldwide. And probably a portion of what ails us is just undiagnosed, untreated iron deficiency.
So
And-
do
and
they
where do
feel
the
like
dogs-
we're not absorbing that through our food system, or what?
Yeah, insufficient amounts of dietary stuff, but then you could potentially have sufficient amounts, but you have malabsorption states. So
Right.
there's a lot of inflammatory bowel disease that's not Crohn's and not ulcerative colitis that could be kind of like subclinical celiac. Like, they don't have the antibodies for celiac, but they do react to gluten some and get inflammation there, so then they don't absorb as well. And so that's one of the considerations, like when you do identify the iron deficiency, then when you're repleting it, if after several weeks and you recheck it, they're not really coming up, then you kind of have to look at the gut and figure out what's happening there. So
And we do see that so much with people with IDD and the absorption issues, and just-
anyone who's had a bariatric surgery, they have malabsorption issues.
Mhm. Yeah. Any other thoughts or questions? Stop sharing. All right. Well, thank you all so much. This was amazing discussion today. So helpful to me, and I hope it was helpful to you as well. We will be meeting, our next session is on July the 8th. And I just want to remind everybody, this session is the only session that has a different time. And we'll be meeting from 11 to 12:30 p.m. that day, based on some scheduling issues. Our topic will be primary care provider order requirements for paid community supports. And Gina, you're good for doing the case presentation?
Yes, if you want to just
Awesome.
forward me the form.
Absolutely.
I asked some of my colleagues if they had one in particular, so I had one that got back with me. And
Super. That's wonderful. That sounds great. I'll definitely get you the form, and you just let me know how I can help support you with that.
okay, thank you.
All right. All right, everybody, take care. Have a great holiday weekend, and I will see you next Tuesday.
Thank you, guys.
Bye, everybody.
Bye.